Very good evening to everybody. Yeah. So as we know, anemia is not merely a reduction in hemoglobin level, it's a complex condition. And we have two excellent speakers with us who will talk about the structured investigative approaches, touch upon the classification of anemia, key diagnostic markers, advanced molecular techniques, and challenges in anemia management. Without taking much time, let's go to introduction to our first speaker, who I know very well, Dr. Amit Khurana. He's a hematology and hemato-oncology, bone marrow transplant physician, Akansha Hematology Center, Surat, who has done a fellowship in hematology in Kolkata and a fellowship in clinical hematology in Mumbai, and fellowship in bone marrow transplantation from Singapore with 10 years of experience in managing over 1,000 of hematology patients. He's an excellent quiz master, and I'm looking forward to his session personally. And he's an expert in bone marrow transplantation as well as medical hemato-oncology conditions. Over to you, Dr. Amit. All the best.
Thank you, Zubair. And first of all, I thank you from the bottom of my heart to invite me at this Kaho platform. And very special thanks to Kaho to give me this opportunity. And today I'm going to discuss with a very important topic where we all fail out in our day-to-day practice, that is macrocytosis, which looks very simple, but is challenging. And for that, I will have a quiz first. You must all solve the quiz. And 5 minutes for the quiz, 10 questions. You just need to write in your answer sheet or whatever pen or paper you have. I will show you the 10 questions, and after that, all the answers you will get in my lecture. So we'll go with the first question. Question number 1. Macrocytosis is defined as MCV of more than 90, MC of more than 100, MCV of more than 110, or MC of more than 120.
Someone has given answer also.
You can write in your paper. The answers will be hidden with you. Fine. We will go with the question number 2. Most common cause of high MCV without anemia is leaving a blood at room temperature, B12 deficiency, diabetes mellitus, or cold agglutination disease. So most common cause of high MCV without anemia. Well, we'll go with the question number 3. All are the causes of high MCV except hyperglycemia, neutrophilic leukocytosis, scurvy, or sample collected from central venous line or PICC line. Is except. Well, we'll go with the question number 4. All of the following is seen in megaloblastic anemia except high LDH, jaundice, Howell-Jolly bodies, and reticulocytosis. What is not seen? Well, go with the question number 5. All of the following statements are seen in thymine responsive megaloblastic anemia except ring sideroblast in bone marrow, deafness, loss of vision, or diabetes. Well, we'll go with the question number 6. All of the following are causes of non-megaloblastic macrocytic anemia except alcohol, liver disease, zidovudine, or scurvy. We'll go to question number 7. All of the following are seen in copper deficiency except ring sideroblast, vacuolated megaloblastoid erythroid precursors, hypolobated megakaryocytes, or basophilic stippling? I think you'll have seen lots of cases of copper deficiency. We'll discuss that. Question number 8. All of the following leads to reticulocytosis with high MCV except hemorrhage, hemolysis, CDE, that is congenital dyserythropoietic anemia, or D, that is partly treated B12 deficiency. Well, the last question, question number 9. What is not seen in pernicious anemia? Hypogastremia, atrophic gastritis, hyperpigmented knuckles, iron deficiency anemia. And the last question we have is question number 10. Which of the following is true regarding B12 deficiency? You will get only high MMA level, that is methylmalonic acid level. B, high homocysteine level. C, both high MMA and homocysteine levels. Or D, high MMA with low homocysteine levels. Well, so this brings to the end of this quiz. You may check your answer in my lecture. So the topic is Aldred macrocytosis is not megaloblastic anemia. Well, so first important thing when we deal with the case of any macrocytic anemia, very important is we are dealing with the size of the RBC. That is very important. And how you define the size of the RBC? Very simple, it's MCV. And what's the formula of MCV? It's hematocrit into 10 upon the RBC count. That we all know very well. And what is the normal range of MCV? That is very important, and that every laboratory should know. The normal range of MCV is about 80 to 100. This is normal range of MCV. And how do you define macrocytosis now out of this range? And the correct answer is, if your MCV is more than 100 femtoliter, your patient has got macrocytosis. And if you get this thing, when you see MCV more than 100, the first thing you must do is you must check your peripheral smear examination. That is must, very important. And why you want to do the peripheral smear examination? The big question. And the answer is, in your MCV underestimates your macrocytosis in 30% of cases. So you can just not deal with your MCV, just the finding, but the peripheral smear examination is must. If you look at the figure on the right side, this is a normal RBC. The pathologist can easily make it out. And the left side we have is a macrocytic RBC. And if you're not very familiar with macrocytosis and all, very simple technique we have. Look at the size of your lymphocytes. And if it's just similar to the size of your lymphocytes in homocytic RBCs, when it crosses more than the size of the RBCs, of the lymphocytes, then it's a macrocytic RBC. Very simple. Once you know that your patient has got macrocytosis, the next thing you need to do is you must classify what type of macrocytosis you are dealing with. And the best way to classify is whether you are dealing with macrocytosis without anemia or you're dealing with macrocytosis with anemia. Then the first in line, we must know what is macrocytosis without anemia. You don't have any anemia, but you've got macrocytosis. And what is the prevalence and incidence of this category? It's very simple, the prevalence is about 1.7% to 3.6%, where most of the patients you are going to get macrocytosis without anemia. And the commonest cause is if you leave your blood at room temperature, and that was your MCQ. If you leave your blood at the room temperature, that is the most common cause of getting high MCV without anemia. Second most common cause is if you get any occlusions of the instrument aperture, or if a patient has got hyperglycemia, it can lead to high MCV without anemia. If a patient has got extreme leukocytosis, again, you will get high MCV. If a patient has got marked rouleau formation, you can get high MCV. If a patient has got cold agglutination disease, again, you will get a high MCV. But not to forget is very important category is pediatric RBCs, where MCV can touch exactly up to 108 or 110 also in pediatric RBCs. And these are the patients, the normal patients. The patient doesn't have any anemia, but the MCV will be very high, 108, 109, 110, and these are the pediatric RBCs. Not to forget is pregnancy that can lead to fluctuation of MCV, and it can also lead to high MCV. Again, not to forget, many patients of Down syndrome, they have got high MCV without anemia. But you must remember one thing, that you may get MCV in normal variant in 30% of cases. And this you can easily pick up by doing repeated peripheral smear examination, and the patients will not have any clinical problems. They don't have any clinical conditions, whether known or existing, no clinical conditions will be present. And this is just because of the genetic predisposition. Next is the category that is macrocytosis with anemia. And when I talk about macrocytosis with anemia, you've got two top types. Are we dealing with megaloblastic macrocytic anemia, or are we dealing with non-megaloblastic macrocytic anemia? And the commonest one, what we get in our day-to-day practice, is we get this megaloblastic macrocytic anemia, which is the commonest one. And the commonest cause of the megaloblastic macrocytic anemia is your B12 deficiency, folic acid deficiency, and scurvy. This is the commonest cause of it. And why do you get megaloblastosis in macrocytic anemia and B12 deficiencies? The answer is very simple. These are the only causes. This is the only rationale behind it. You have ineffective erythropoiesis, plus you've got dysplastic erythropoiesis. This leads to defective DNA synthesis, lack of normal maturation with increased RBC proliferation. So what you get is large erythroblast with high NC ratio, and that leads to your nucleocytoplasmic asynchrony. This is what it looks like in the bone marrow. What you see over here is megaloblast with an open sleeve-like nuclear chromatin, a hypercellular marrow with the erythroid hyperplasia, and the megaloblasts are large with high NC ratio, nucleocytoplasmic asynchrony, and very important is open sleeve-like nuclear chromatin. This is another exactly the next figure what we have. This is a very good presentation figure of megaloblast with a high NC ratio, nucleocytoplasmic asynchrony, and very important is open sieve-like nuclear chromatin. This is very typical of B12 deficiency or folic acid deficiency. What else you get in megaloblastic anemia? You get this giant metamyelocyte. This is a hallmark, giant band forms and giant metamyelocytes. Again, you can see over here, you can see this giant myelocytes, giant metamyelocytes, and giant band forms. That is the feature of megaloblastic anemia. If you're not able to see megaloblast, but if you see the giant metamyelocytes, giant band forms, and giant metamyelocytes, you're done with it. Your patient has got B12 deficiency. Another very important feature what you have is you see hypersegmented neutrophil. This is typical hypersegmented neutrophil where the lobes can go more than 6 lobes. That is the definition of hypersegmented neutrophil. What else you get in megaloblastic anemia? If you look at the iron stores will be increased. That is the hallmark. Even you can see sometimes ring sideroblast also in a case of megaloblastic anemia because of the increased iron stores and ineffective erythropoiesis. Very important thing you not get anywhere else, but only in B12 deficiency, that is macroovelocytes. And if you're able to get these macroovelocytes with hypersegmented neutrophil, you can easily tell your patient has got B12 deficiency or folic acid deficiency. So these are macroovelocytes, and along with that, you get this hypersegmented neutrophil in your peripheral sphere. That is a telltale sign that your patient is suffering from B12 deficiency. Because of ineffective erythropoiesis, what you see also is Hobel-Jolly bodies. That is the telltale sign of any ineffective erythropoiesis. Apart from this, you may also get this basophilic stippling, which only suggests that your patient has got ineffective erythropoiesis. In every patient of megaloblastic anemia, you will get cytopenias. You can get anemia, you can get leukopenia, you can get thrombocytopenia, but cytopenia will be clearly evident in your CBC report. But very, very important is your MCV in a case of megaloblastic anemia will cross more than 110. More so, it may also cause more than 115. There is no other etiology in entire globe where your MCV is 120, 125, 130, and your LDH is more than 1000 with indirect hyperbilirubinemia. It's only B12 deficiency. So MCV of 120, LDH more than 1000 with indirect hyperbilirubinemia, you must look for B12 deficiency. And very important is your reticulocyte count will be very low in B12 deficiency, and that was your MCQ. Apart from this, what is important is your red cell distribution width. Because of B12 deficiency, you get these macroovulocytes, and that will also mix with your normal size RBCs also. And hence the distance between the RBCs will tend to increase. And this will lead to a high red cell distribution width in case of megaloblastic anemia. Next, very important cause of megaloblastic anemia, apart from B12 deficiency in India, is scurvy. Where the typical clinical feature of scurvy is you get this perifollicular hemorrhage, which you can see very closely around the follicles. You see this perifollicular hemorrhage. So if you get high MCV with anemia, B12 is normal, folic acid is normal, patient is coming with gum bleeding, you must check for this perifollicular hemorrhage. And if you happen to get this perifollicular hemorrhage, you are dealing with vitamin C deficiency, that is scurvy, that is causing megaloblastic anemia and not your B12 deficiency. This is another feature of scurvy. You get this bleeding gums. That is the feature of megaloblastic anemia in a case of scurvy. And you must not forget, very important is, if your B12 is normal, if your folic acid is normal, if the patient has got normal vitamin C levels, the next most common cause is you must think of congenital cause of a megaloblastic anemia. And these are the defects in the de novo pyrimidine synthesis, which leads to a clinical condition that is known as orotic aciduria. Similar feature, what you have also is a critical condition, is a congenital condition where you can get this megaloblastic anemia. When you rule out B12, folic acid, and scurvy, is you must also rule out a congenital condition that is known as TRMA. And what is this TRMA? It is thymine responsive megaloblastic anemia. What is this TRMA? It occurs because of a mutation. And this mutation is SLC19A2 mutation. What this mutation does, it is responsible for a high affinity thymine transport gene mutation, which leads to defective nucleic acid production. So if your patient has got SLC19A2 mutation, he may end up with TRMA, that is thymine responsive megaloblastic anemia. What are the features of this TRMA? You will get megaloblastic anemia, no doubt, but you will also get diabetes. That is a worst feature. You may get deafness. And very important, you may get this megaloblastosis in the bone marrow. And that was your MCQ quiz. What is not the feature of thymine responsive megaloblastic anemia? These are the triad of it. You get megaloblastic anemia along with diabetes, along with deafness, and very important, in the bone marrow, you will see exactly the same clinical picture like in case of B12 deficiency. You will get hypercellular marrow, you get erythroid hyperplasia, you will also get megaloblastosis, you will get giant metamyelocytes, you will get giant myelocytes, giant band forms. But this is not B12 deficiency. This is thymine responsive megaloblastic anemia, where the picture is very clear cut with deafness and with diabetes. And very important, like in B12 deficiency, you get ring sideroblast and high iron store. Again, in TRMA also you get this ring sideroblast in the bone marrow. Coming up next, very important thing, that is pediatric conditions where you get this megaloblastic anemia. And we all deal with these pediatric cases very well in the day-to-day practice as a hematologist, because I also deal with children with anemias. So most of the patients who come to me are pediatric, and this pediatric patients, the most common cause of megaloblastic anemia is because of the breastfeeding mothers with B12 deficiency. This is the most common cause of megaloblastic anemia. The mother is B12 deficient and they are breastfeeding and the child gets B12 deficiency. So if not B12 deficiency, what else in children? That's very important. And this is a congenital condition. You must not forget this. And this is known as Imerslund-Grasbeck syndrome. This is a very important condition which every hematologist and every pathologist must know. What is it? It's an autosomal recessive condition where you get this congenital cobalamin malabsorption. It affects the children between 1 to 5 years of age. It's because of the cubilin mutation which is present on the intestinal brush border, which leads to non-specific proteinuria, as well as it is also associated with duplication of renal pelvis. So there is a defective in the cobalamin malabsorption, which leads to B12 deficiency in children. Another congenital condition which the children suffer from is Lesch-9 syndrome, which we must not forget. This is an X-linked recessive condition. It's a inborn error of purine metabolism, where the patient has got all the congenital conditions, malformations, like starting from mental retardation, microcephaly, seizures, chorioathetosis, spasticity, gout. But the most important feature which the child will tell you is about self-mutilation. And the patient comes to you with self-mutilation, you will diagnose this condition very clear-cut that you are suffering from Lesch-9 syndrome. And this is how it looks like, self-mutilation. The child bites its own lips. The child will bite own nails, own fingers. They will self-mutilate themselves. And this is the biggest problem with the Lesch-9 syndrome, where the patient can have megaloblastic anemia. And the very important characteristic feature is this self-mutilation. Again, you can see the self-mutilation. The child has bitten up their own nails and the fingers. This is the telltale sign of Lesch-9 syndrome. Next very important thing is, let us go with the opposite way now. What are the causes of non-megaloblastic macrocytic anemia? And when I tell about non-megaloblastic macrocytic anemia, what are the causes? The causes are the most commonest causes we must know first. And the commonest cause is alcoholism in the Indian scenario. That is the most common cause. So if your patient has got macrocytic anemia and no megaloblastosis, non-megaloblastic macrocytic anemia, most common cause is alcoholism. And why do you get macrocytosis in alcoholism? It's very simple, because alcohol itself can lead to macrocytosis. The patient can lead to have folate deficiency in alcohol liver disease, or the patient itself has a chronic liver disease which can lead to macrocytosis. Up next, what is the second most common of non-megaloblastic macrocytic anemia? Is smoking. So alcohol and smoking has to be ruled out when you are dealing with non-megaloblastic macrocytic anemia. Third important cause is what you see in ICU settings, that is hypoxia, that can lead to non-megaloblastic macrocytic anemia. And the next in line you must think of is chronic liver disease when you are evaluating a case of non-megaloblastic macrocytic anemia. Not to forget the drugs. There are so many drugs which can cause non-megaloblastic macrocytic anemia. And out of these, the most common what we have is anti-cancer drugs that can lead to a high MCV. And if we look at the anti-cancer drugs, on the top, we have got a very important alkylating agent, that is cyclophosphamide, which can cause a high MCV. Hydroxyurea, when the patients of sickle cell disease are on hydroxyurea, as well as the patients of myeloproliferative neoplasms are on hydroxyurea, that can lead to a high MCV. Not only this, we have got methotrexate, azathioprine, 6-MP, cladribine, cytarabine, and 5-fluorouracil that can lead to a high MCV. Not to forget, there are so many antiviral drugs which can lead to a high MCV. And these are the two most common antiretroviral drugs we must know. One is ridovidin and stavudin. This can lead to a high MCV. Not to forget, the patients of diabetes are on metformins, and metformins itself will lead to non-megaloblastic macrocytic anemia. Patients who have got history of seizures and on anticonvulsants can also lead to this non-megaloblastic macrocytic anemia. And we have got three main drugs for this: phenytoin, primidone, and valproic acid. Diuretics, most common diuretics which can lead to non-megaloblastic macrocytic anemia is trimethoprim, which we must know that. And there are lots of antimicrobials which can also lead to non-megaloblastic macrocytic anemia, and they are listed over here, starting from pyrimethamine, sulfamethoxazole, trimethoprim, and valacyclovir. These are the four most common antimicrobials which can lead to non-megaloblastic macrocytic anemia. So when you are evaluating any case of macrocytosis, we must look into account whether the patient is taking any of these medications or not. Anti-inflammatory drugs, rheumatoid arthritis, patient, very commonly I get left to right. In my practice, I get encountered with these conditions. Patient is on sulfasalazine and patient is referred to me because of megaloblastic anemia. And I just tell the rheumatologist that your patient is on sulfasalazine. That's why he has got macrocytosis. Not to forget, leukemia can lead to macrocytosis because of the high number of WBC count that can interfere with your Coulter reporting. And very important is sometimes your anemia of chronic disease can also lead to non-megaloblastic macrocytic anemia. Very important when you're dealing with the patients of elderly patients who are coming with anemia and you see high MCV. you must think of very common condition, that is myelodysplastic syndrome. And just similarly in the younger age group, what we have is congenital dyserythropoietic anemias, which can also lead to a very high MCV. So in elderly, you have got MDS, and in young children, you have got congenital dyserythropoietic anemia, which the bone marrow findings can be just similar to each other. Hypothyroidism, not hyperthyroidism. You must know that. So hypo will lead to high MCV and not hyperthyroidism. So hypothyroidism is a cause of high MCV. Aplastic anemia, this is a very important finding where you get a high MCV. And if your patient has got aplastic anemia, or you must think of any congenital bone marrow failure syndrome, and out of this, the most common congenital bone marrow failure syndrome, what we have in a day-to-day practice is Fanconi's anemia. Second most common congenital bone marrow failure syndrome, what we have is Diamond-Blackfan anemia, where the patient can have just absence of the red cell series, also known as pure red cell aplasia. No red cells at all, no erythroid series at all. One thing we must know that many of our thalassemia patients who come to us after splenectomy can also have got these high MCV levels. And this can lead to a high MCV anemia. In your OT settings, very famous drug, what is known as laughing gas, that is nitrous oxide, can also lead to a high MCV. What else can lead to a high MCV is other vitamins which are deficient, starting from nicotinic acid, pantothenic acid, riboflavin deficiency, and very important, that is copper deficiency. This is what a copper deficiency looks like. And every pathologist must learn to pick up this copper deficiency, because this is the world of 2025 where the bariatric surgery is rampant now. And this bariatric surgery patients have got this copper deficiency. And I have got every day and night, I'm referred by a bariatric surgeon with anemia, with high MCV. And when I do the bone marrow, I'm able to tell him that this is copper deficiency and not B12 deficiency. This will not correct with your B12, but it will correct with the deficiency of copper. And what you see in copper deficiency, very important finding, you will see the cytoplasmic vacuolation. Exactly, you'll get this megaloblastosis with high NC ratio, nucleocytoplasmic asynchrony. You can also get this high MCV, erythroid hyperplasia, but very important is you see this cytoplasmic vacuolation, which is very important, very common in your copper deficiency. So cytoplasmic vacuolations in the erythroid will tell you that your patient has got copper deficiency. Plus, what you also see in copper deficiency, you also see this ring sideroblast. So the combination of two, erythroid hyperplasia with cytoplasmic vacuolation plus ring sideroblast in a patient who has undergone bariatric surgery, you must give a diagnosis. Your patient has got copper deficiency. So the history is very important. Bariatric surgery, that's the most common history you will get. Apart from this, you will also get cases of non-megaloblastic macrocytic anemia, and very important is from the gastrosurgeon or from the gastroenterologist. And these are cases of Wilson's disease where the patient can have a macrocytic anemia. And this occurs because of the copper excess. And very important feature, what you see is this Kerr-Flisser's ring, which is very important characteristic feature of Wilson's disease. This is the characteristic. Very important, you must know to differentiate that whether your patient has got round macrocytes or not. So if you see these round macrocytes and not macroovelocytes, moment you see macroovelocytes, it's very clear, it's B12 deficiency. But if you see round macrocytes, you are looking for other disease which is not B12 deficiency, and that is round macrocytes. You've got number of presentations and number of conditions. And out of this, Wilson's disease is very important, where you see these round macrocytes. Apart from this, when you see the round macrocytes, you rule out B12 deficiency, because in B12 deficiency, you are seeing macroovelocytes and not round macrocytes. But moment you see round macrocytes, you must start thinking about MDS and must searching for this very important anomaly that is known as Pelger-Hood anomaly, where you get hypolobated neutrophil, a spectacle-shaped neutrophil, and a hypergranular cytoplasm. This is the feature of MDS. You get Pelger-Hood anomaly with round macrocytes and not macroovelocytes. And the bone marrow will have erythroid hyperplasia with erythroblastosis, erythroid hyperplasia, and very important with a high NC ratio, that is nucleocytoplasmic ratio and nucleocytoplasmic asynchrony, And very, very important is you see this hyperlobation, multinucleation, binucleation, and nuclear budding, bridging, etc., which is the feature of dysplastic erythroid series in case of MDS. Other feature what you see in MDS is very important. That is, you see this hypolobated megakaryocytes. This is a very important feature. And once you see this hypolobated megakaryocytes, you are dealing with MDS. Again, you can see a very good picture of megakaryocytes in the bone marrow. You see this hypolobated megakaryocytes, which leads to a very important condition that is known as MDS with 5q deletion, where you see this hypolobated megakaryocytes, the very characteristic feature of MDS with 5q deletion. Again, very important is this round megakaryocytes. This is very important. Sometimes you may also get these giant platelets in case of MDS. And very important is in peripheral smear, you may also get this hypogranular platelets, which is again a feature of your myelodysplastic syndrome. Very important is in your MDS patient, and your patients will have got erythroid hyperplasia. Your patient has got megaloblastosis, but more than megaloblastosis, the patient will not have open cellulite nucleochromatin here. The patient will be megaloblastoid rather than megaloblastic. It just resembles your megaloblast, and hence it's known as megaloblastoid. Plus, your patient has got dense nucleochromatin. That is what is important you need to pick up. It's a dense nucleochromatin, and it's a megaloblastoid feature in case of MDS. This is the opposite in children, what you get. Similar feature, it's congenital dyserythropoietic anemia in children, where you get nuclear multinucleation, binucleation, multinucleation. This is the feature what you see in case of congenital dyserythropoietic anemia, who can just present to you with just a macrocytic anemia in childhood. And when you do the bone marrow, you will see this erythroid hyperplasia with nuclear multinucleation. Binucleation, multinucleation is the feature of CDA. Very, very important you must know is what are the causes of high MCV with reticulocytosis. And when I tell you a high MCV with anemia with reticulocytosis, you must think of only two conditions. Only two conditions you must think of. Are you dealing with hemolysis or are you dealing with hemorrhage? So reticulocytosis with high MCV with anemia, only two conditions, hemolysis and hemorrhage. And when you tell about hemolysis, you must search for a very important thing, that is cystocytes. Moment you see these cystocytes, you are dealing with intravascular hemolysis, and you must tell your clinician that your patient has got high reticulocyte count, probably because of intravascular hemolysis, because I'm looking for cystocytes. And I'm able to see lots and lots of cystocytes. This is a pathognomic condition which for one disease, and that is you all know very well, that is TTP. Similarly, if you get this hemolysis, you must also search for spherocytes. Because if you get spherocytes, you are dealing with extravascular hemolysis. And if you deal with cystocytes, you are dealing with intravascular hemolysis. So intravascular cystocytes, extravascular, you got spherocytes. But the challenging task, what we have when you deal with high MCV anemia is masking. What do you mean by masking? Masking is very important. This occurs in those conditions where a patient has got a megaloblastic anemia which is masked because you see low MCV levels, because your patient may be having thalassemia minor, your patient may be having iron deficiency anemia, your patient may be having other nutritional deficiency also, or your patient may have mixed nutritional deficiency, and hence your high MCV can be masked because your patient is having combination of all this. Your patient, you may be misleaded that your patient, you will miss out, your patient has got high MCV. So thalassemia minor, iron deficiency anemia, other nutrition deficiency, and mixed nutrition deficiency, this can mask your megaloblastic anemia. What next you must know in this series is what are the causes of megaloblastic anemia, and the two most causes we know very well is B12 deficiency and folic acid deficiency. And how does the clinical presentation of these patients come to me in my day-to-day practice? They come to me with significant pallor. They come to me with stomatitis. They come to me with red, swollen, smooth tongue, which is very common with B12 deficiency. Patient can have angular cheilitis. Patient has got very frank feature, that is hyperpigmented knuckles. If you get this hyperpigmented knuckles, you are surely dealing with B12 deficiency. Patient can have indirect hypobilirubinemia leading to jaundice. Patient can have bruising because of platelet dysfunction in B12 deficiency. Patient has got premature graying of hair, and I have graying of hair started for about 10 years back, but I don't have B12 deficiency. The premature graying of hair is the feature of B12 deficiency. Patient can have ataxic gait. Patient can have bilateral symmetrical paresthesias. Patient can come to you with just abnormal proprioception. And patient can come to you with just loss of vibratory sense because the problem is neuropathy. Patient can have dysesthesia also. Patient can have hypoesthesia. And very important, patient can have this peripheral neuropathy in a case of B12 deficiency. Patient can have just memory loss in B12 deficiency, repeated forgetting, many small things. Recent memory loss is the feature of B12 deficiency. Mood swings is another feature. Sometimes patient is laughing. Sometimes patient is very sad. This is mood swings is again feature of B12 deficiency. Patient can get hallucinations to extreme level of B12 deficiency. So if you get all these symptoms, you must do certain test. A very important test you must do is you must go for MRI brain and spinal cord test. And what you need to do in MRI brain, what you see is you will see symmetric increased T2 weighted images in the posterior lateral columns of cervical and thoracic part of spinal cord. And once you see that, you are dealing with subacute degeneration of your spinal cord. If you are folate deficient, your mother is folate deficient, you will not pass on to the babies when they are pregnant actually. And this can lead to neural tube defect also. This is the biggest disaster in the Indian scenario where the mother is folic acid deficient and you will end up with this hydrospitalis, the condition which is very near and dear to me. Sometimes B12 deficiency can lead to a hypercoagulable state, can lead to high homocysteine level, and this high homocysteine level can lead to deep vein thrombosis also. B12 is a very common condition to have infertility in our Indian population. So most of the patients who come are referred to me because of infertility. I do check the B12 and folic acid level, and if they are deficient, I will correct it first, and then rule out other causes of infertility. So what is the cutoff of B12 and folic acid levels in megaloblastic anemia? Simple cutoff we have is cutoff of 200. So if your patient has got level of B12 less than 200, definitely he has got B12 deficiency. If between 200 300 is borderline, more than 300 is unlikely to be B12 deficient. Similarly, for folic acid deficiency, you must know the cutoff. If you're less than 2 folic acid level, definitely has got folic acid deficiency. Between 2 to 4, borderline. More than 4, unlikely to have folic acid deficiency. Last but not the least, we will also like to discuss this very important entity. We must not forget that is pernicious anemia. Why it occurs? It occurs because of anti-intensive factor antibody, because of or anti-pertussis antibody. And if you get this anti-intensive factor antibody, it has got a sensitivity of 50 to 70% and specificity of 95% to diagnose pernicious anemia. Anti-pertussis antibody has got sensitivity of 90% and specific 50% to diagnose pernicious anemia. But if you combine both the tests, that is anti-intensive factor antibody plus anti-pertussis antibody also, the sensitivity increases to 73% and specificity increases to 100%. Plus, what you see in pernicious anemia, you will see gastrin levels increase. Why so? Because you got atrophic gastritis, and that's why you get hypergastrinemia, and that was your MCQ. And when you do the upper GI endoscopy, you must get atrophic gastritis, and once you see atrophic gastritis with a high gastrin level, you are dealing with pernicious anemia. Last but not the least, I will also like to focus on one important thing because many clinicians and many pathologists do ask me, which is better? Is it serum folate is better or RBC folate level is better? Which one is better? The answer is very simple. The best test, what you must do is serum folate or RBC folate. The best is always RBC folate. Why? Because it remains stable throughout the lifespan of the cells and it is not affected by dietary changes, and it will give you prior 3 months of estimation also. But the best of the best test to diagnose B12 deficiency is very important, that is MMA, that is methylmalonic acid levels and homocysteine levels. In your B12 deficiency, both your homocysteine and methylmalonic acid levels will be increased. But in your folic acid deficiency, only your homocysteine levels will be increased and your methylmalonic acid level will be absolutely normal. So take home message from my side when you're dealing with any megaloblastic anemia is macrocytosis is defined as macrocytosis without anemia and macrocytosis with anemia. Most common cause of macrocytosis without anemia is prolonged storage of blood at room temperature, followed by hyperglycemia, leukocytosis, rouleau formation, and agglutinates. Macrocytic anemia is again further divided into megaloblastic and non-megaloblastic. Most common cause of megaloblastic macrocytic anemia is B12 and folic acid deficiency. And if you're dealing with non-megaloblastic macrocytic anemia, the most common cause, as I said, was alcohol, and alcohol, followed by smoking, chronic liver disease, drugs, MDS, hypothyroidism, and not hyperthyroidism, aplastic anemia, congenital dyserythropoietic anemia, and hemolytic anemias. Peripheral smear examination is must to be done with every case of macrocytosis. And if required, you must go for a bone marrow examination also. But remember that approach to macrocytosis is mathematics. And if you go one step wrong anywhere, you will miss the final diagnosis. Well, thank you so much for the patient hearing.
Thank you, Dr. Amit. That was a blockbuster performance.